Palliative care physicians are often in the position of being called to see cancer patients who have pain. And one of the most important things that a palliative care or hospice physician needs to know is how to suspect that the patient might have a malignant spinal cord compression. So when the patient who has cancer complains of back pain, even with no neurological findings, the important thing for them to know is that patient could have an impending spinal cord compression, and they need to urge, if it's appropriate within the goals of that patient's care, to urge an emergent MRI. And the second slide asks that question: what is the only test that will rule out a malignant spinal cord compression? Second thing that's very important for the palliative care practitioner to know is how to advise the family, because how is this going to be treated? Let's say it's found, a spinal cord compression is found, and the orthopedic doctors are coming in and saying you need surgery, and the radiation therapy doctors are coming in and saying you need radiation. The palliative care practitioner can be the translator. So it's important for them to know what the evaluation is going to entail. So it'll entail an orthopedic spine evaluation. They'll try to figure out the patient's prognosis. They'll try to figure out how stable the spine is, and you'll really need to know what the patient's goals are, and you can feed that back to all of the practitioners. Then it turns out that there are certain things that would favor surgery followed by radiation. Certain kinds of tumors aren't very sensitive to radiation. If the spine's really unstable, radiation isn't going to help that. So the third slide shows the criteria by which you can help the family and the patient figure out, does surgery make sense? There's a little bit longer rehab for that. Or does radiation alone make sense for that patient? As a palliative care practitioner, you need to be the one that can empower the patient and the family to really think these things over with the doctor teams. And finally, the last thing is rehab. What if the patient is a shorter time to live than anyone had hoped, and yet they're offering surgery or they're offering radiation followed by rehab? How does a family decide whether just to take the patient home with physical therapy or a little bit of rehab, or really commit to an intensive rehab program? So our rehab physician will speak to, and the last slide speaks to all the reasons you might want to commit to an intensive rehab treatment for a patient versus just a regular rehab. What's important is to assemble a team. So if you're the palliative care clinician or the hospice clinician, you need a sympathetic radiation oncologist, spine or neurosurgeon, and a really expert rehab person, and you can bring that team together to help your patient really get the best outcome if they do have a spinal cord compression. That we as palliative care practitioners need to advocate for making diagnoses before we just treat a symptom. And so we need to help the patient and family make the right decisions, even if they have advanced illness, to maintain their function, if that's really what they want. With a spinal cord compression especially, to lose the ability to walk, to lose your bowel and bladder function is devastating, even if you only have a couple of months to live. So a palliative care practitioner or hospice practitioner's role is to make that diagnosis and then help that family decide within the therapeutic options what the right thing is for them.